Welcome, everybody. My name is Pam Fury, and I am System Manager of Clinical Documentation for Alameda Health Systems. Today's topic will be discussing renal failure. And I first want to go through the challenges that our clinical documentation department runs into when reviewing the medical record. So the first challenge we see is that CKD is often documented, which is great, as a diagnosis, but it does not have a documented stage correlated with it. And therefore, we will query you to get the correct stage. However, we will give you all the clinical indicators and evidence for the stage. Secondly, one of the challenges is that a patient with historically and persistent elevated creatinine is missing the renal diagnosis of CKD. And so if it's a persistent elevated creatinine, that is CKD by definition of a diagnosis. Number 3, patients sometimes have a non-renal primary diagnosis, and they'll also have an abnormal creatinine. Then they're missing the renal diagnosis of AKI. So an example of this is the PDX might be dehydration. It's non-renal, or it's just dehydration. And they also have an infectious process and CHF. And if they do have an abnormal creatinine, then we need to also add to that list of problems and diagnosis the renal diagnosis of AKI. Another thing that we see is that there is treatment for renal issues that are just ordered for the PDX that the patient has without the documented associated PDX. So, for instance, if IV fluids are ordered for a different PDX, but the associated renal diagnosis is not documented. Another thing to just keep in consideration of is very often there's a fluid imbalance or fluid balance clinical signs and symptoms also with a missing renal diagnosis. So whenever that's also just a hint for you when you're working on your patient and reviewing their medical record. The other challenge is if you monitor the creatinine lab and you check and it looks like it's within normal limits, you might not write a renal diagnosis. But what you need to remember is that a patient can have a creatinine that is within normal limits, but watch for the trend of the increasing creatinine because it can still trend up by 0.3 increases and stay within normal limits. But you can still have a renal diagnosis even if the creatinine is within normal limits. The last thing that we see frequently is that if in the beginning of the medical record you might document ATN as suspected or it has been mentioned, but it's never followed through the medical record and indicated if it was either ruled out or resolving or resolve. So if you ever mention it that you suspected in the beginning, make sure that you carry it through the medical record and indicate if it's ruled out or resolving. Some of the options you're going to get when we send you a query is we will indicate if we're looking for chronic kidney disease with the stage, and then we would insert the stage for you what the proper diagnosis is, at least based on the clinical evidence that we've identified, which is also at the top of the query. The other diagnosis there option you'll have is AKI or ATN, or sometimes there's AKI on CKD with the stage, and we would put the stage in there. So just as a reminder, when we send you a query and we give you your choices of what the diagnosis could be, we will always give you, before the diagnosis, the story. We'll tell you the clinical findings, we'll tell you your treatment, and we'll tell you any risk factors. And of course, if you don't think it's there, you say clinically, if you don't agree with any of those diagnoses that are presented, you're allowed to say clinically unable to determine or other. Now, what I want to take you through is the definition, the risk factors, and the clinical guidelines for chronic kidney disease. This is going to get a little bit detailed, but it's just a reminder and a reference tool for you when you're looking at the patient labs and the signs and symptoms to have as a reference. And this is also in your tip sheet, your laminated pocket guide that you have. So the definition of chronic kidney disease is a persistent and a progressive irreversible loss of the kidney function. And we mentioned that a little bit earlier. It's persistent. It also is defined as an abnormality of the kidney structure or function that is present for over 3 months and does have some health implications. Chronic renal failure, chronic renal disease, chronic renal insufficiency are all the same diagnosis that equals chronic kidney disease, but it needs to be written as chronic kidney disease to the best of your ability. What are some of the risk factors for chronic kidney disease? Diabetes, hypertension, and obstruction, autoimmune diseases, UTIs, or even recurrent UTIs, aspirin and NSAIDs, and acetaminophen. So if you see any of your patients on these medications and these conditions on a chronic basis, that's just a hint and a risk factor for getting chronic kidney disease. So what are the clinical guidelines? The clinical guidelines are a decreased GFR less than 60 mils per minute, or you can have a measure of the kidney damage, which includes persistent albumin in the urine, urinary sediment abnormalities, electrolyte or other abnormalities due to renal tubular problems, or an abnormal biopsy, abnormal imaging, or a history of a kidney transplant. The other clinical guidelines that I have here is the stages for the CKD based on a stable baseline GFR. So a stage 1 is a GFR greater than or equal to 90. A stage 2 is a GFR 60 to 89. A stage 3 is a GFR of 30 to 59. Those are all considered comorbidities. A stage 4 CKD of a GFR of 15 to 29. A stage 5 CKD with a GFR of less than 15, and or stage 6 of ESRD are all considered major comorbidities. That's very important for us to capture the stage. That's why you will be queried, because it has major implications on the severity of illness and the resource consumption needs for a patient. Now we will go through the definition, risk factors, and clinical guidelines for acute kidney injury. There is an increase in the creatinine to 1.5 times greater than or equal to 1.5 times your base creatinine, which is thought to have occurred within the prior 7 days. That's one way to define acute kidney injury. I'm going to repeat that. If there's an increase in the creatinine to greater than or equal to 1.5 times the base creatinine that has occurred within the prior 7 days. Or you can measure it by an increase in the creatinine by greater than or equal to 0.3 mgs per dl from a measured baseline within 48 hours or less. Or you can measure it by a urine output that has been less than 0.5 mils per kilogram per hour for at least 6 hours. The AHA, the Alameda Health System's normal range for creatinine, because it's very slightly sometimes from medical center to medical center, the normal range is 0.7 to 1.3 mgs per dl. So there's 3 different ways you can quantify using the creatinine and or the urine output to determine a diagnosis of acute kidney injury. What are the risk factors for AKI? Dehydration, obstruction, glomerulonephritis, and or ATN. What are some of the clinical guidelines for diagnosing acute kidney injury? First one, there could be a sudden reduction in the kidney function that's usually within a period of hours or days. Diagnosis-wise, acute renal failure is the same thing as acute kidney injury when it comes to diagnosis. AKI is used more frequently. Okay, so then when the baseline creatinine is unknown, you might not know a patient's baseline creatinine when they come in. What you can use for the baseline is the lowest creatinine that you get during the hospitalization. So that becomes your baseline by which you measure the definitions up above. For greater than or equal to 1.5 times the baseline, that can be prospective or retrospective with broad interpretation from a prior 12 months if there's no known CKD. So you can either go backwards or forwards interpreting the baseline creatinine within a 12-month period before or after if there is no known CKD. For greater than or equal to a 0.3 mgs per dl, you can only look forward prospectively with their baseline being measured within a 48-hour period, and that requires 2 measurements. So looking forward, a patient is admitted to the hospital, You get their baseline, and by going forward, their baseline is increasing within 48 hours by 0.3 on 2 different measurements. The other clinical guideline is for less than 0.5 mils per kilogram per hour, that there's a reduction in the urine output based on weight. And then lastly, the BUN should not be used as an indicator of AKI since it can be elevated for many other reasons. Okay, so that's the definition, risk factors, and clinical guidelines for AKI. Now let's go through acute tubular necrosis, which is ATN. So what is the definition of ATN? ATN is actually AKI, but it's AKI due to the dysfunction of or the damage to the renal tubules. And this was very interesting to me that ATN is the cause of AKI in about a third of the hospitalized patients. So if you do diagnose AKI, a third of the time that patient has ATN. So make sure you look back and you look at what is the etiology of the AKI? Is there any damage to the renal tubules? What is the risk factor for ATN? Prolonged hypotension, so situations of shock, IV contrast, sometimes sepsis or shock, major surgery, rhabdo with myoglobin in the urine, and drugs and toxins are risk factors. So, and very frequently we see patients with rhabdo because there's a lot of patients that are found down where safety net hospital, and there are clinical indicators for ATN. What are the clinical guidelines to write the diagnosis for ATN? One, that it meets the criteria for AKI, because the patient must have AKI to have ATN. Two, that it's expected to take greater than 72 hours for renal function to return to the baseline when you're giving them IV fluids, which is measured by the creatinine level. Next, that you can use this measurement optionally, but that the urine sodium is greater than 40 milliequivalents per liter, or the FeNA, the fractional excretion of sodium, is greater than 2%. The guideline, if you're going to use greater than or equal to 1.5, can be prospective, again, or retrospective with the broad interpretation from a prior 12 months if there is no known CKD. It's just a reminder. Okay, so let's go through some AKI examples and see if you can answer why the patient has the certain diagnosis. So a patient has a creatinine on admission that is 2.0, and you give them IV fluids and it decreases to 1.0. Do you think that patient has CKD or AKI or ATN? The answer to that is it was probably, the patient was probably dehydrated, which was corrected with fluids, so there is no type of renal failure here. Number two, a patient with no known CKD is admitted with dehydration, but they have a creatinine of 1.9 with a previous creatinine of 1 6 months ago. So this patient has AKI. And the reason is that the creatinine of 1.9 is greater than or equal to the 1.5 over the baseline creatinine that they had 6 months ago. And all of these clinical evidence and criteria are in your tip sheet, and with the likely color of gold on your tip sheet. So you can have this as a very quick reference guide for you. Okay, another example is a patient has CKD. They have a stated baseline of 1.8, but they are admitted with a creatinine of 2.5. But you give them IV fluids, the creatinine level decreases to 1.6 with the fluids. So what is the true baseline? The true baseline is really 1.6, but the patient does have a creatinine of 2.5, and that is 1.5 times the baseline. So AKI, based on criteria guidelines of 3 and 4. Number 4, a patient is admitted with creatinine of 1.2, and they have an increase to 1.6 within 36 hours following a cardiac cath. So that patient does have AKI, and I want you to see the guideline number 4, which is the 0.3 increase of your creatinine within a 48-hour period of time. And once again, I want to thank you for attending, and feel free to reach out as we are partners in improving our clinical documentation, and call any member of the clinical documentation department. Thank you so much.